Dear colleagues, I will present something that I've been working on for the past few years. It's called fluoroscopic vitrectomy, and I do believe that it might change the way we are doing the vitrectomy in our surgeries. So up to now, we have the ability to stain the vitreous with triamcinolone and recently Lutein 300, which is a lutein-based dye. We can use, of course, trypan blue in certain scenarios, brilliant blue G, ICG, but with debatable success, and it can facilitate a little bit more the cortical work than the stroma of the vitreous. So what I did is started with a fluorescein-assisted vitrectomy, and later on I turned into a fluoroscopic one because I tried to minimize the concentration and the volume of the fluorescein which is used. I use a diluted fluorescein to 0.1%. In previous studies was shown that 0.6% concentration is safe, but in my experience, if you put too much fluorescein inside the eye, it will take too much time to clear the fluorescein from the vitreous and to continue on for the next steps of the surgery. So I try to minimize the amount of fluorescein which I put in the eye. Waiting time is around 15 to 30 seconds. The fluorescein is infinitely soluble in water, and we know that the vitreous is actually 90% water and 10% collagen, so it penetrates inside the vitreous. I use for fluoroscopic visualization a modified digital filter from the Ingenuity plus excitation light like we are using in a slit lamp microscopy or fluorescein angiography. So this is my first video on the topic, and the question is, do we really see the vitreous? And here you might see a comparison between a fluorescein-assisted vitrectomy on the right screen and a fluoroscopic vitrectomy on the left screen. So with the fluoroscopic modality, you might see more of the stained tissue with the less concentration and amount of dye used compared to the classic view of the white light. Anyways, the classic fluorescein-assisted vitrectomy might be useful, especially for the peripheral view, because a lot of vitreous is actually left in the eye, or at least I realized that after starting to use a fluorescein staining of the vitreous. Probably I didn't do as much as thorough vitrectomy because I simply don't see the transparent tissue, which is the vitreous. Here is a comparison between the Lutein 300 and how it stains the vitreous, and later on you will see compared to the fluorescein. The Lutein is actually, in my opinion, more in terms of action compared to the Kenalog than to a staining agent which can penetrate the vitreous. All these staining modalities, Kenalog and Lutein, are actually covering the surface of the vitreous or the remnant surface of the vitreous without staining all the remnant stroma of the vitreous body. So here you see more or less I removed the Lutein. Is really good for staining the posterior hyaloid. Obviously is well seen, but it's a mechanical interaction. There is no chemical interaction between the vitreous body and the Lutein staining. And now in the same eye I apply a fluorescein, and you will see how much vitreous is left inside. So this is switching to the blue excitation light, and you might be amazed how much vitreous body, especially in the periphery, is left inside. So I think that having in mind that cleaning the periphery might be one of the most important parts of our surgery, we still don't have a well-proven method of staining of the vitreous. It's all comes to experience and anticipation and guessing where is the transparent vitreous, or playing with the angle of the light pipe in order to highlight the vitreous fibrils. So you can obviously see that there is a lot of vitreous body in the periphery, and you can see the layered structure of the vitreous periphery. Here is another example on that. Obviously, I improved the digital filter, and I tried to create a filter where you can see well the underlying retina, not only the vitreous, because one of the first problems was you see well the vitreous, but you don't see the underlying retina, and you might create iatrogenic damage somehow. But with improving the digital filters, I think that we might reach a better level of seeing the vitreous body, because it's one thing to see what you are removing, and other thing to anticipate whiplash effects, sphere of influence of the vitreotomes, etc. And why not use it under the retina? And in cases where you have redetachments, where you doubt where are the breaks, I found that putting it with 41 gauge needle in this particular case under the retina and displacing it with a PFCL, it first increases the contrast in the periphery, and later you see where is actually the causative break for the redetachment. In the past, a blue staining agent was used for similar purpose, but the thing with the fluorescein is that it actually stains the vitreous around the break. And you will see in a moment that this is a link of 4 rule redetachment or detachment, and you will see how the supraretinal fluorescein will peak through a break around 12 o'clock. No lower break was found here, and due to the increased contrast, you can work really close to the peripheral retina without damaging it. You see here there is a star fault, but now you see the egress of supraretinal fluorescein from the causative break, which is totally on the opposite side. So it might be useful in such scenarios. And of course, there is a question about safety. And the most important thing from this slide is that the fluorescein was used as a marker for supraretinal transport of retinal cells, and is completely harmless. And the only thing that you might consider is an allergic reaction, which can be managed in the same way as the ambulatory fluorescein angiography. Thank you.